Welcome to the Invisible Thermostat, how climate change and weather extremes are rewiring global mental health. This video explores the profound link between rising temperatures, environmental factors, and severe psychological outcomes. A popular misconception, the winter myth, links darkness and isolation to peak psychiatric emergencies. In reality, the summer reality shows that actual global data across 20 countries reveals peak psychiatric emergencies, including suicide, in late spring and early summer. The core of the problem begins with expected seasonal variations. This is then amplified by acute meteorological factors, such as sustained heat waves. The outermost ring represents force multipliers, human-driven climate factors, acting as systemic psychological shocks. This trigger matrix highlights three key environmental factors. Continuous heat causes thermoregulation failure. Air pollution triggers neuroinflammation and stress. Extreme events cause trauma and social infrastructure collapse. Each has distinct psychiatric outcomes and lag time. Heat and pollution create a synergistic spike. Specifically, high levels of nitrogen dioxide combined with an increase in wet bulb globe temperature can drive a nearly 50% increase in suicide risk. The wet bulb temperature indicates heat stress when humidity is high. The biology of heat and light involves three key mechanisms. The sunlight paradox links rapid spring luminosity to shifts in serotonin and melatonin. Seasonal cholesterol cycles show low cholesterol correlates with higher suicide occurrences. PUFA depletion during the winter to summer transition can trigger depressive episodes. The medication trap illustrates how essential psychotropic medications inhibit the body's ability to sweat. When external heat waves push temperatures above 30 degrees Celsius, patients can suffer from hyperthermia and severe physiological stress, leading to behavioral outbursts and emergency hospitalizations. The diagnostic vulnerability matrix shows that sustained heat over 7 to 8 days elevates the relative risk for emergency hospital admissions for schizophrenia. For organic disorders like dementia, an extreme increase in heat-related mortality is noted. Substance misuse and mood disorders also show increased risks with rising temperatures and heat waves. Demographic danger zones include the rural male farmer, where drought-related agricultural decline increases suicide risk. The urban poor are trapped in concrete heat islands, leading to increased anxiety and depression. The isolated elderly suffer physiological failure combined with social isolation, heightening their vulnerability. The aftermath of extreme events follows a predictable curve. The initial spike occurs in week 1 with acute distress. The delayed wave, around month 3, sees substance misuse hospitalizations rise. The chronic burden, lasting up to 3 years, involves sustained major depressive disorder and long-term damage. The healthcare pressure cooker shows how the climate mental health convergence impacts emergency services. Up to 14% of emergency mental disorder admissions are attributed to hot temperatures. Ambulance dispatches for suicide attempts spike dramatically, and hospital admissions lag by 5 to 14 days following the heatwave peak. A global blind spot exists, with a statistical disparity in research. Only a fraction of global studies originate from low and middle income countries. This absence of data reflects a lack of functional psychiatric infrastructure, not an absence of climate-driven suffering in these regions. The climate healthcare feedback loop is a catastrophic, self-reinforcing cycle. Climate extremes intensify, leading to psychiatric morbidity surges. This causes healthcare utilization spikes, which in turn leads to a carbon footprint expansion from highly carbon-intensive healthcare systems, further worsening the climate. The perfect storm of climate psychiatry occurs at the intersection of environmental extremes, biological vulnerabilities, and systemic fragilities. This zone of catastrophic morbidity represents the highest risk for severe psychotic exacerbation and psychiatric mortality. Building the mental health thermostat requires an action plan with 3 pillars: predictive outreach, clinical adaptation, and systemic resilience. This includes integrating weather forecasting for crisis alerts, adapting clinical protocols, and decoupling healthcare from high carbon footprints.